Hi, I'm Dr. Gerbert, and I am an obstetrician gynecologist at MAMMOGRAMS Associates, and I started here in 1988, so I've been here 32 years. And over those years, I've sort of developed a little bit of a niche for menopause and menopause problems and management and discussion. So I thought I might talk a little bit about that today. So one of the very common things we talk about is the average age for menopause. And the average age for menopause is 51. But there can be really quite a huge variation in timing of menopause between different people. A lot of it seems to be familial. People tend to go through an earlier menopause if their mother or grandmother or sister did, or later. And menopause really is when you have had an absence of a period for a full year. But those years leading up to that, what we call perimenopause, can be even up to 10 years leading up to that, where hormone patterns are changing and things are changing, and that's sometimes where the people have the most trouble or the most bothersome symptoms. And some of the common things that I often hear are people, as they reach their 40s, ladies will often discuss about how their periods have become heavier. And that is extremely common and extremely annoying for many people, because everyone's thinking they're getting close to menopause, so their periods are going to space out and get lighter and everything's going to be grand when they stop. But really, usually before that, they get closer together and much heavier. And that's all related to the changes in hormones as the progesterone levels are falling. The estrogen levels might not be falling as quickly, and that leads to this relative deficiency of that kind of hormone, which can be managed if needed with just a little boost of hormone if it becomes too annoying. The other things that change during that perimenopause are frequently people talk about sleep disturbances. They don't sleep as they used to. Maybe they can't get to sleep, or more commonly, they get to sleep but they wake up a few hours later and have trouble going back to sleep, which is very annoying. Hot flushes during the nighttime in the perimenopause period are very common, where night sweats, people are waking up from those, especially in those days prior to the period. Is very common because that's when the estrogen and progesterone level are falling, and that's sort of is similar to the whole brain sees that's similar to menopause, because that level starts to fall and that makes the brain react to that, and that's what leads to the hot flushes. And that sleep disturbance often leads to mood changes, which is a common concern. The PMS-type symptoms actually worsen during perimenopause, and people think they normally would be getting better because, again, their hormones are decreasing, but they're often heightened, like breast tenderness, the mood changes, the irritability, that kind of thing. During that perimenopausal period, there are quite a few options for treatment for those symptoms. Like, for example, for the bleeding, we can sometimes supplement with a hormone. It's very common in healthy people to offer a low-dose birth control pill that could be used to sort of bridge that gap to get through to menopause time, to manage those heavy and closer periods so they're spaced more normally. Sometimes even just some vitamin supplements are helpful, and some life modifications like exercise and yoga, deep breathing, dressing in layers to help with the hot flushes, a fan at the bedside. Those kind of things can be really a lot of relief for those nuisance symptoms. As people get closer to menopause, or their periods are stopping, sometimes their symptoms heighten quite a bit, and they will talk about frequent and annoying, rather debilitating hot flushes, or vaginal dryness, or, like, again, the irritability and changes in just not feeling well. And some people, their periods stop just like a light switch. They stop suddenly. Others take a long time to transition to their periods spacing out further and further apart. And symptoms vary tremendously widely between people. So some people transition really with very little symptoms and breeze right through. Other people suffer a bit more, and there's a lot of things that can be done that are reasonable to handle those symptoms, like sometimes a vitamin supplement or some other natural herbal supplements could be considered to be effective, and some people do well with those. Others will consider a hormone replacement therapy, and there's been a lot of controversy and fluxes in opinion about hormone replacement therapy in the last number of years. So for the symptoms of menopause, really the thing that benefits people is estrogen. But estrogen really can't be used alone, because if people still have their uterus, they have increased risk of uterine cancer developing if they take unopposed estrogen. So they have to balance it with progesterone. So the hormone replacement therapy is an estrogen and progesterone combination in women without a hysterectomy. So that is very similar to birth control pills, but in a different dose. So in the perimenopause, that's why we often are still using birth control pills, because we're getting contraceptive protection and the benefit of it. But then when the contraception is no longer needed, we can use lower doses to get the benefit of the symptom relief without needing the contraceptive. So we can go to a different dose of estrogen and progesterone. And some people will benefit from, like if they're having that low libido, they will consider adding some testosterone or some other these bioidentical compounded formulas that we can try to boost that up. So back in 2002, there was a big study that came out called the Women's Health Initiative, and that was it was a huge study, but it was played up huge in the media about the negative side effects of hormone replacement therapy, and there was a huge swing in the pendulum in the use of hormone replacement therapy at that time, from where it was previously used pretty much for everybody, regardless if they had symptoms or not, to now nobody was using it. And gradually the pendulum sort of swung back, and it became more moderate as the data was further assessed to be what is the realistic concern of hormone replacement therapy. And for some people, it's quite a quality of life choice. I'm really big on quality of life issues, so I think if you know what the risks are and you choose to take something like hormone replacement therapy to improve your quality of life, I think that's very reasonable for some people. But and back when that WHI study came out, that was 2002, and there was a huge pendulum swing where everyone went off of hormones. I think that people later sort of reanalyze things and look, what is the actual risk? Because everybody's fear of hormone replacement therapy is breast cancer. That's what people automatically think when you talk about it. And realistically, the risk of breast cancer from hormone replacement therapy is pretty small. The increase in breast cancer incidence is really small. It's only about 8 out of 10,000 women. So the real risk that I see for hormone replacement therapy is an estrogen problem of blood clots. So that's why people who have had a history of blood clots or strokes or heart attacks are not really good candidates for estrogen. The breast cancer risk, even though it's real and it's important, and especially if it's in your family, it is a smaller risk than the risk that really people never even consider when you start talking about it. and going into it, people often ask that about, you know, how long will it last, and it varies widely. So you don't really know. And there, you know, people say, oh, the average is about a year, but I mean, that's not even really necessarily accurate, because they found that people after a year have either been treated or they just stopped complaining about it. So it might be much longer average for some, but and like you said, others hardly have any symptoms. So, you know, going in, I think you have to have that discussion, because it's really about the quality of life. And then what risks do you have? What's your family history? What's your personal history? And what are your what are your goals? If your goals are to be symptom-free, then you're going to be more willing to take medicine. Right. And it continues to increase the further you get from menopause. So that's what we see much later, that sometimes people are having, you know, they notice a lot of problems with intimacy and need to address that further. That could be an over-the-counter solution, or it could be a prescription solution too. And for the vaginal dryness issue, you know, when we talked about you could use maybe some vaginal estrogen, the absorption from vaginal estrogen is so small into the system versus if you're taking it systemically for relief of symptoms. So vaginal estrogen doesn't relieve symptoms of menopause other than vaginally. And a lot of people at perimenopause or really menopause talk about sort of a brain fog that they experience, and how they just don't feel like they used to. And a lot of times, I think it might be sleep related, even if they're not realizing they're waking up. Their sleep pattern is that they're becoming very light in their sleep and not getting the quality of sleep that they used to, which probably contributes to that. And some like joint and muscle aches. I see that commonly, although the book doesn't really talk about it, that they experience things like that. And a really big is weight gain. Is so many people notice weight gain at menopause, which is a very unfair system, because if you eat the same and do have the same activity, really you're going to gain weight, because the metabolism just slows down. And the other thing that's really quite prevalent is the change in the distribution of weight. So women tend to sort of lose that more hourglass thing and become more straight, which is very frustrating, because even if they manage to keep their weight the same, their pants don't button the same because their waist size has changed. So yet another very unfair thing. Sex drive too, that often people talk about how their sex drive decreases at menopause. And I mean, it's not 100%, some people's actually gets a little better, but frequently it's a problem. And there are different solutions for that too. Some are more effective, some are less effective, none are fabulous, but there are, you know, both prescription and non-prescription alternatives to consider for that. You know, like contraception during that perimenopause time, is people are often curious about, you know, do they still need to use contraception during that time? Or people who were using maybe oral birth control pills and then had permanent sterilization, or their partner had a vasectomy and they stopped their contraception, and then they realized what a wonderful thing it was, because it made everything very regular and predictable. So sometimes there's a big discussion about contraception then and when to stop it. But normally we really don't stop it till you've really reached that final period, just to be sure. And it is pretty customized, because there's a lot of different ways to deliver estrogen. You know, there's pills and there's patches and there's creams and gels, and you know, based on sort of your own medical history and what you like as far as what appeals to you for how you would like to utilize it. And the dosages that we want to try to, you know, not the same dose doesn't work for everybody. So we have to have a lot of different choices to try to get to use the least amount of medicine possible to get you the desired relief. But at menopause, as the estrogen level falls, estrogen is really protective for bone density. And so women lose that protection that they had for bone density once they're reaching menopause. So they become more at risk for osteoporosis. And so often that's when we start doing our bone density testing to see how people are faring, if they're losing bone density quickly or where they are sort of on that whole scale. And there's multiple treatments, but one of the benefits of using estrogen, sort of a side bonus, is the protection of bone density. There are a lot of other treatments for bone density, and it's really important for people to keep their calcium intake adequate and their vitamin D especially adequate, because there's really a lot of evidence to show how important vitamin D is in many different functions. And people in this part of the country, because of the whole sun, tend not to have, they tend to be more at risk for having low vitamin D. So that's something that often we're checking on a regular basis to make sure that it stays adequate. Commonly, people will have bone density screens on some sort of regularity to see what their rate of bone density loss would be, and try to prevent it from when it becomes, because once you've lost that bone, it's really hard to build it back. But it's much more effective to try to prevent the loss, which is really important with exercise. And like I said, calcium intake and vitamin D. Family history plays a really big part in it, though. And then there are prescription treatments if needed. They're available, and there's a lot of new ones recently that seem to be doing quite a bang-up job of even building back some bone density. Well, we'd love to have it on everybody right at menopause, about age 50-ish, but not all insurances agree with that. So we a lot of times have to defer to what the patient's insurance allows. But someplace between 50 and 65, everybody should have their first one. I think things that at menopause that really become common topics are like vitamin D again. That's sort of a biggie. And vaccinations, for immunizations for like shingles, and then later on pneumonia. So making sure that those things are all up to date. Mammograms, obviously. So it's really important to continue annual screening, because even though the need for contraception obviously isn't needed after menopause, there are other screening things that are so important that become more important at menopause, like bone density testing, immunizations, and consideration for other menopause symptoms. So it's a time when people need to be aware that they need to keep their annual appointments. One thing is sort of important is that if you don't talk to your healthcare provider about sort of how you're feeling and what your goals are, they don't really know, because some people, like I said, they really are very adamant. They want no symptoms, no side effects. They want to have treatment for everything. And other people are more stoic, less interventional. They want to manage it more naturally. So it's really important that you have good rapport with them and tell them sort of what you're feeling, what you're thinking, and what your goal is, because your goal might be completely different than the next person's goal. And it really has to be very customized. And you're not, in any of these treatments, you're not married to it forever. You can try it, see if it works for you, and if it's not the right formula, there's a lot of other different formulas that we could try till we get to the right one. So sort of like trying on women's shoes, how we have to try on 10 pairs till we get the one that's just right. Sometimes it's like that, but sometimes the first pair fits fine. So it's really important to just sort of stick with it until you're satisfied.